Hello and welcome. Welcome to this Zoom room organized by Eaglet Eye. And we're so thrilled by all the participants here, of course. And but in particular, we are very honored by an all-star team of people wanting to talk about their experience with the Eye Surface Profiler. And I would love to introduce them to you. Our moderator, our chief and captain, Dr. Tom Arnold from Memorial Eye in Sugar Land, Texas. And next is Alex Gibberman. Dr. Gibberman is in Loveland in Ohio. And Dr. Heidi Miller is practicing in Sacramento, California. And we have Sheila Morrison, Dr. Sheila Morrison in Calgary, Canada. And Sir Brian Tompkins from the UK, Northampton, where he practices. And we couldn't be happier with such an expert panel. And we're really looking forward to this the discussion between the experts here. There's a possibility for you to the audience to ask questions, so please use the chat to do so. And with that, Tom, I would love to give the microphone to you and get the process going. Thank you.
Thank you, Arnie. It's certainly a pleasure to be here today. It's an honor to work with you and Eaglet, and it's certainly an honor to moderate this esteemed panel of colleagues. And not only are they colleagues, but they're also very good friends. So very, very happy to be here. This is exciting technology. We all have been working with this for a while, and the future is so exciting and so bright. We think that empirical fitting is here to stay, and we'll be discussing some of that in our presentation today. So with that, let's get started. So the first thing I would like to ask is the panelists, how does profilometry help you in your practice? And Alex, I'd like for you to lead off, please, sir.
Sure. So thanks, Tom, and thanks, Eaglet, for putting this discussion together. One of the first things that comes to mind is speed and efficiency. So, of course, there is always that one patient who is happily penciled out about 15 hours to spend in your office. For example, this was taken yesterday in my office, and Bernie just left an hour ago. But for everyone else, profilometry with the ESP, really, it greatly reduces chair time and thus the number of follow-ups required to nail that perfect fit, which, patients really appreciate. Whether they're coming from 2 hours away or 5 minutes away, most people have, better things to do than make 10 trips to the office. So, it's become the norm, even with complicated cases, to expect finalization after 1 or 2 visits. So that's kind of the first thing. And then the actual image acquiring process is also very, very quick. I typically use a drop of anesthetic followed by, something like blink gel tears, paint the eye with fluorescein. And then once the patient's lined up, it's a simple click and primary gaze. You really want to hold their eyes wide open. And just like that, you've got the potential for a 20 millimeter diameter image. I usually get about 3 shots on each eye and then, choose the best image from there, or you can actually merge your top 2, which is another pretty cool function called Smart Merge, which we can talk about a little bit later. But really, at this point, we can get over refraction and send the data right to the lab of your choosing.
Another aspect, thanks Alex for that. Another aspect that I really enjoy about Eaglet is the precision that you get. I know a lot of us that are on here either are on the one end of the spectrum where we've been really experienced with using scleros for a long period of time. And then also we could be new to fitting scleros. And I think, doesn't matter where you are in terms of your experience, the amount of precision that you get with these measurements is incredible. There could be a patient that I thought the fit looked great and I've done scans on, and just seeing that information that the instrument is predicting should be the parameters for that lens, those small modifications just make that fit even more precise, more accurate. And I'm even seeing an incredible improvement in vision in some of these patients where I thought maybe this was the best their vision would be, but maybe with slight modifications based off of the software, the lens is centering better, the parameters are a little bit more accurate to the eye surface, and the patients are actually getting improved visual acuity, which I think is a great thing to think about depending on where we are, even with our experience with scleral lenses. I don't know if Sheila, you wanted to talk a little bit more about your efficiency and practice over with your labs.
Of course. So when it comes to working efficiently with labs, this is what I've been tasked to discuss briefly. And to start, one of the most kind of fun and important things that we found in our clinic is the fact that the eaglet is compatible with a large variety of different lens designs. And so in that diversity, we've really been able to adapt the technology into, designs that best fit patients with a whole range of different eye shapes. What works best in clinical practice is to go ahead and figure out, what lab is the one that's closest to you. What is your choice design? What are a few different designs that would work for the types of patients that you see? And then become a master of the choice of design that is best for your practice. Software is available to us, and that's another area that certainly has helped our practice to be able to modify lenses ourselves. And probably the most important tip, I guess, that I would pass on to this group in regards to working efficiently with labs when it comes to any ocular surface profiling, ocular surface mapping, would be to really watch quality control. And so I know the ESP team in all of our labs work almost, it feels like we're on the clock to continue to make software better and better. And so quality data in is very important for quality products out. And so in the beginning, when you're getting started with the ESP, I'd strongly encourage you to work closely with our lab. The team is here on this slide, and they're all understated, will not be the first to put their faces on a slide. So I had to say thanks for all of the times that this group has helped me in our clinical practice, and certainly encourage you to reach out to the labs to check your quality control when you first start working with the ESP.
Thanks, Sheila. Great roundup. And thank you to Alex and Heidi for their beginnings of this talk. We are in some pretty tough times in practice. This is COVID era, and I don't think it's going to go away for a very long time. So we are trying where we can to minimize the time that we spend with a patient, but maximize the efficiency, be communicating to the lab with the best possible data, and generally make a lens that is a first fit, maximum second fit option. And ESP has revolutionized that capability. ESP has put fitting lenses into the 22nd century, and it's advanced in such a speed during the COVID period and lockdowns that we are 5 years ahead of probably where we would have been earlier. I think that to have this equipment in your office, to have, well, in the UK we would say practice, but you Americans all say office, to have the capability to instantly, quickly take a massive area of data across the sclera, which, as we know now, is much, much more complicated than we first thought, is an absolute joy in practice. And let's be honest, we're kind of all in business here. It maximizes the fee income with a minimum time spend. So as an important factor within business, that's a really great bit of kit to have.
Those are all excellent points. And I'll point out too, Brian, the advantage for us, especially in America, we have Heidi in California and Sheila's in Canada and Alex in the Midwest. I'm in the South. Patients travel a long time to see us. In many cases, they come from far away. They miss time from work. They miss time from school. So getting it right the first time or second time, minimizing those follow-up visits and remakes is extremely important. And I agree that the eaglet helps us.
Yeah, we're finding that here now, being the privilege to be able to use it in practice. We're getting people traveling. Somebody yesterday traveled 9 hours. Now that's a UK traveling. So
wow. Yeah,
that was a worthwhile visit for him.
That means something in the UK.
Yeah, it
People
does.
don't travel. Great. So, we all know the long history of scleral lenses in particular, that they've been fit for many, many years. But why do you feel, why do you feel that profilometry now is so important to your practice?
Because I think we've all been fitting, I've been fitting scleral lenses for 40 odd years, albeit there with a big large gap in the middle. And when they came into certainly the UK some years ago now, the question was about ease of fitting, and it was considered that you could put a simple scleral lens onto an eye and maybe tweak a little bit here and tweak a little bit there. Since working very closely with ESP, you realize actually the sclera is a lot more complicated than you first thought. And if you look at the kind of patterns that both Tom and I have, these are typical ESP images of what a sclera looks like. And the beauty of the ESP profilometry generally is it will break down the complication for you, and it will allow you to be able to look at the complexity of the lens. Is it going to be a spherical? I don't know the last time I did a spherical sclera. Is it going to be toric? Is it going to be quad specific, or is it going to be much more complicated than that? And so very largely the complexity of the sclera is dictating, there you go, there's the scleral profile. It's a very simple single press button. And that shows the level of complexity you may be going. And then that complexity and data gets sent directly to the laboratory to be able to build the correct form of lens, from either complete bespoke or to a first fit profile of a lens from a known lab of a lens you love and use on a regular basis. So it speeds up the process of fitting your favorites, or goes completely to tailor-made if needs be.
And to amplify that, Brian, were excellent points. I think it makes you have a more intelligent discussion with your patient. And you can say, look, you know, this is how complex it's going to be. These are the challenges. I can help you, but these are the potential challenges we're going to have. And I'm fitting you in this lens because. So
And
really,
it's
facts and data.
Yeah, and it's educational to the patients. They don't even realize how complex their cornea is, and then the sclera getting extra complexity, which is never the same complexity as the cornea. They're often opposed to each other in cases. So yeah, its educational tool is well worth it.
Yeah, I agree 100%. And, you know, remember too, statistically, 67% of scleras fall into that asymmetric or, you know, quad specific irregular category. So you could spend an incredible amount of time trying to guess how many microns to alter certain quadrants. Just a quick example, you know, when I first started fitting sclerals, I had a patient who had keratoconus, but also had a number of EOM surgeries as a kid, and you know the eye was like a mogulled ski run, right? And I mean, we went through I don't know how many lenses before I gave up, you know, went with a hybrid option, but that same patient, I ended up seeing a number of years later when we had the eye surface profiler, and it was a completely different outcome. You know, the lab capabilities, of course, with quadrant specifics, you know, over time that helps as well. But this was a much different experience also for the patient, you know, and then on our end, you know, as you said, you know, chair time was cut down significantly. You're not getting stuck with the remake or shipping charges that might occur after so many swings and misses, which, you know, at the end of the day, that eats away at the profit margin. So yeah, it's just amazing stuff.
Alex, I have a question for you. Just before, hey, when you're refitting one of those patients, how long do you pull them out of their habitual lenses before you feel that you're ready to take a map with the ESP?
So, you know, I believe Jason Jedlicka had started doing a study on this, and he showed that it took about, I don't quote me on this, I want to say he was able to show it really took 5-6 days for the sclera to completely go back to normal. But for so many people, that's not really realistic. So, you know, if they're really dependent on these lenses to see, then, you know, at the very least, we try and say, well, take them out for the weekend, and then we'll do it first thing on Monday morning. Or as an alternative, we can do one eye at a time, you know, try and function with you know, one lens, we'll fit the other eye. And then once we get that one done, then kind of swap it. So that's kind of a alternative method. But yeah, I guess I would say probably that weekend buffer at a minimum.
That sounds like 48 hours or so sounds about right for those patients. Yeah. Yeah. You know, and that really does contribute to the quality of data that I was talking about. The images and the, you know, the huge amount of data that we can get from these ocular surface topographers and from the ESP is, so incredible. And so basically the way that we use this data can vary. We can pull things like iris diameter, pupil size, looking at the height of the eye in any particular location. So at a chord of whatever you're looking for, we can get this all from the ESP, and it's really been valuable, over the past couple of years to be able to use that data for, in research settings, but also, in just making those early decisions when we're meet and greeting our patient for the first time and explaining what their options are, working them up to get a great view of what their comprehensive ocular surface topography looks like is definitely the number one step, so that we can clearly, first as practitioners, understand what their options are, and then also use that data to explain to the patient what their options are. And it's all based on ocular shape. And so again, the ESP has been absolutely essential and a tool to be able to collect this data. We can then use that data for a variety of ways, or in a variety of ways. And historically, before all of our manufacturers have caught up so nicely here in 2021 with such cool software that they have to apply the data that we collect to lens designs. A lot of, the beginning, we would use this data. Okay, this is an eye that has more of a toric pattern, let's say, with a height difference of so many microns. We can apply that still today if you're doing a diagnostic lens fit, or use the first lens fitting software within the ESP or our manufacturer's programs to pick a trial lens. And that's one way that in our practice, we certainly use the data. And then of course, the freeform lens design is where we're at today in 2021. It's definitely the direction that we've been moving whenever possible. There's, pros and cons of all of these different designs. And I wanted to include at least 1 or 2 case reports, just pictures and images, just to show, here's a patient we saw this month in our practice. As you can see, lots of surgery for this patient, double PKP, displaced IOL, trauma, fixed iris, and really irregular ocular shape overall, 2 lenses to final for 20/25 vision. And that's largely, based on the data-driven designs that are available today. Our next slide will show, again, another just case that we had actually last week in the clinic, a different style of fitting, but again, the data that we collect now today can translate into these lenses. This one was just a one fit med, totally ESP driven. Patient habitually had been in contact lens or sclerals with chronic redness, instability, history of multiple fits and discomfort. And, it's been a couple years since we had fit this patient, pulled him out for 48 hours, refit fully data-driven, so empirically designed, which is really cool. Didn't even have to put a lens on this patient's eye, using the data that we could collect from the ESP, using the patient's prior refractive parameters, so base curve and power of the most successful lens visually, applied into this super lens, had a great clinical result for our patient.
Now, Sheila, I had a question for you real quick before I moved on. With your patients that you're empirically fitting, like this one was an existing lens wearer, but if they were coming in with no lenses prior, brand new, would you still put a lens on the eye in office to get some sort of visual component? Or have you done just strictly empirical fitting?
You have to. So really, today it'd be nice if we had our super instrument that I think we've all been talking about over the years, with maybe the possibility of having a super scanner that can look at things including lengths inside the eye, taking some kind of average on even an irregular cornea to come up with a starting lens. You can build it using different equipment, which I've done in the past for patients occasionally, but it's really not practical. It's much better and more, we very commonly will put that diagnostic lens on. And there's so many other things. I think there'll probably be a little section coming up here. I believe one of us will touch on it more, but diagnostic lenses are great for showing a patient what the lens feels like on their eye, ruling out, if you're fitting them for something that, neuropathic pain or ocular surface discomfort, putting a lens on an eye is still something that we do all the time. Mm-hmm.
All right. Yeah, I'm doing that as well.
Sorry. Not to mention, just to make sure that they can even get a lens in their eye.
Yeah.
Yeah, we had a discussion just ourselves last week, I think, when we were planning for this. And we use a system where we're always going to train the patient to do application removal before they even go down the route of ordering a lens, because otherwise it's kind of a wasted time. There are just 1 or 2 who can't manage at all. And Alex, to your point about historically how long to leave the lens off, the beauty of ESP, if you use the tangent angle function, is you can actually see the impression of a lens. So if somebody's left it 3 days, measure, and you can see there's an impression there, then you're not going to go down a final lens at that point. You're going to have to ask the patient. Now that's the challenge if they're traveling a long way, but ultimately ESP is so accurate, you can actually see the old impression of the lens if it's still existing.
And that actually happened with me recently, Brian. I had a patient come in. This is going to be an example I was going to use, but I had a patient come in and they were referred by an outside office that had fit them in sclerals before. It was a difficult fit and it was fitting poorly. And she had been to the ER actually 3 times already from not being able to get the lens off. That's how tight the lens was fitting. And when she came in, I told her, I think you're going to have to be out of the lens for at least a week. And we did the approach that Alex had mentioned where we did one eye at a time because she needed to have some vision to go to work. And even after that 1 week of being out of the lens, when we did that scan, we could see that indentation mark. It had been that tight. So I actually had to have her come back and continue being out of that lens for a while. So we say 48 hours, 72 hours, but there could be patients that are very poorly fit, and you'll be able to see that when you do the scan and know that that's just not going to be great data. And going back to what Sheila said, if it's not great data and a good quality image, garbage in, garbage out, the lens is not going to be fitting well and you're going to be kind of chasing your tails. So I do think that aspect is really important, and make sure that you're, looking at those images. I know if you have a technician in our office, I'll see the patient first, just like I would for any consult, take a look at their eyes, get an idea, but a technician is doing the scanning for me. And I've spent a lot of time working with her one-on-one, also with the Eaglet team, separate kind of team viewer sessions to make sure we understood what is a good image. Because if your technician can just acquire an image, that's great. But if they don't understand what a good image is, maybe they only take 1 or 2 for each eye, and then you're moving the patient back into that room to take some more images. So that aspect I think is really important. A lot of times I get questions on, does this make your first visit much longer? And I just want to reiterate that no, not really. A lot of times we're doing imaging to begin with, and unless you're struggling with, image acquisition, which can happen, I think it's made the entire fitting process much quicker. That first day, you'll be spending more time to devote good quality images, but those first lenses are probably going to be close to perfect. You'll probably need to do some modifications. So it has saved a lot of time.
Yeah, I find we got a lot of assistance starting this from Arnie and Rayner and their team about understanding what's a good image, what's not, and artifacts, identifying artifacts in the maps. We learned a lot. Our staff took to this very easily. I think the instrument is easy to run, and the image capture is quick. And we take several images, as I know you all do, and there's a star feature where my staff will tag these, I believe, are the best images, which we'll look at. And if I agree, those are the ones we use. But thing is, patients don't know. It's all new to them. So how long it takes or how many tests you do, they have no, they're not going to get impatient with you because they have a problem and they're there to fix. So I'm not bothered by the amount of testing we do.
Yeah, in regards to that, the time, it kind of reminds me of the myopia clinic or any other specialty clinic, and putting in the extra time on the front end saves you time in the back end. It really does. So getting that measurement for us has become something that's part of pretest. Whenever possible, both eyes, don't neglect one. How many times do we get a patient in referred for a monocular fit, and then lo and behold, a couple lenses later, a couple of visits later, they're asking to be fit in the fellow eye. And so usually that's another little tip that it just came to mind too, whenever we're working up a patient, including corneal topography, and whenever possible, try to get both eyes done, because you'll probably 30% of the time need it, and you'll just have to go back and do it if you don't do it on the front end.
That's a great point. I fit a lot of scleral lenses on a normal cornea because the abnormal cornea feels so good, much better than the soft toric lens they have in their other eye. Yeah, absolutely. That's a tremendous point.
Yeah, and really a good point for Arnie and Renier, who's hiding his video here, and understandably as well. I've seen his face. And ultimately, they're always available for reference in terms of, is this a great image? And if the team, or even you, are new ESP users, we've got a lot of new Eagles nesters coming into the fold at the moment. And Renier is just genius at saying this is a great image or not. So before you use it, it's a quick support button request, bang, you take the star, you tick the box, bang, and off it goes to Renier, and he'll say, yeah. He's got nothing better to do with his baby. He just, you know, is plenty of time on his hands.
Always available for us, right?
I think our next slide talks about, what are the main advantages to the ESP, for you and your practice, for you and your patients. I think we've covered a lot of it. So briefly, let's just go around and hit the high points. If I could ask the panel, what are the main benefits to you in your practice?
If it's my turn, one of my favorite parts of this technology is really to be able to build value in your practice. And so, obviously we are here to provide the best quality vision, healthy vision, best visual outcome where a patient is, able to achieve the goals that they have in their life. One of the ways in our practice that I have found, or that we've all, probably this whole panel, I know would agree on this, that we find using technology to our advantage to create value. And it's not only the patient perception, it really comes down to their experience and final outcome, which is, the safety, vision, all the comfort, that experience. But, we'll show patients using imaging like this, the full process, and it can be a very powerful tool to take an ocular scan, like you see in the center photo of our patient, and show them why they need a medically necessary contact lens that is a custom design versus, a toric landing or a sphere or something that they've never really heard of before. And it really translates. You can see this lens actually really closely matches that profile. And really, it's a way that we can build value in our practice, justify why we charge the fees that we charge. We do not undercharge for these services. I think I saw a question come in on the chat line asking about, a good price point for these things. And I'll open to the rest of the panel here. I know in our office, we charge a set global fee for medically necessary fit. And I'll be honest, the fees are, not low. They're definitely mid to high in our community. And we do that because we stand behind our technology and are not afraid to show it off to patients and use it to our advantage. And ultimately, it does benefit the patient. They see that in their experience and final outcome. We want them to know that they're getting the best. And it's all part of being in a competitive market today, for sure.
Yeah, I mean, we are, actually it was last year now, we literally lost it about a month ago, but we were Technology Practice of the Year, and having this kind of technology in the practice is super crucial, because this year we're Contact Lens Practice of the Year in the UK. So overall, that the technology of ESP is giving us such a big understanding, giving us that efficiency. And it's that fitting. Now, some might argue, well, surely you're losing the skill set. Well, I kind of entirely disagree with that, because we need the basic skill fitting to be capable to understand what is not just a good fit, but an excellent or superb fit. And ESP just takes it that next step, that extra level, to give the best option that we can possibly give to the patient for their vision and their comfort on a regular basis.
Right. I couldn't agree more. And just, as far as freeing up time, why it's like your amblyopic or, a kid with low or a high plus prescription, why give them that disadvantage when you could focus on their perception? So giving them that lens allows them to use their energy toward higher level functioning. And I think it's the same when it comes to fitting medical lenses, in that, we're putting aside some of the time that's spent just finicking around and making that lens at least fit and be comfortable, so that we can really focus on paying attention for complications and look at ways that we can optimize vision even more than it maybe was.
Yeah, and the idea of the empirical element of the first fit function, which is a really simple button pressing exercise within the technology. So we've taken the beautiful scan, and that takes time, it takes practice, it takes the right mix of fluorescein on the front of the eye. If you look at the Eaglet website or look on some of our social media, we've put a kind of a reference of how best to get the fluorescein to get the best reflectance. I do find it's great to have two people doing, one holding the eyelids and one taking the actual shot. But once you've got that scan and you've picked the starred best one and you've put it into the click first fit, there is such lab neutrality. You can pick any of your favorite laboratories here and literally add in the lab or the design you want to do. And in fact, if you watch the video ongoing now, it actually talks you through in 1 minute what you can do. And this is how long it takes within the practice itself. So it gives you that first lens. Now, as Alex said, and in fact, all of us agree, it's perfect in people who've never had a lens before to try a lens on eye. So how bad is it to pick the wrong lens for the eye? And much as we might be experienced, we're never going to get some of these complex, wobbly scleras to fit well. Whereas ESP guides us to that first fit lens and gives us the first chance to wow the patient. We're about exciting them, entertaining them, educating them, but wowing them with vision. And many who've seen me lecture have seen me often put a towel on my shoulder to describe the best technology that we have. And that towel is because lots of our patients cry through happiness. And my suits, when I wore suits back in the day, used to get ruined by salty tears down one shoulder. So now I've gone to scrubs, I don't care so much, but at the end of the day, that wow factor comes from the technology and the first fit algorithms.
How about you, Heidi?
Yeah, I mean, I have definitely, like I said, had really great success with this. In the beginning, I was so unsure of like, who would I use this for? Who would I not? And like I said, I did a lot of sessions with the Eaglet team just so that I could really understand what I was looking at. And now in using this, it's such an easy tool to use, and it provides so much data, and same kind of results like Brian's saying is that you're getting that wow factor. Even if you already work, we already are spectacular, right, as doctors, but this is just taking it to the next level and providing that technology. Patients come to you because they want the best, and this technology can definitely do that. When you're using this in office, a lot of times, I don't know how your offices or your practices are set up and where you'll have your instruments, but before we'd have to go in and type everything in an order form separately or call, and whatever your method of ordering is fine. But what's really awesome now too is that there's a potential to do direct connect with the Eaglet. And I think this is primarily in the US, but they are trying to expand outside the US as well for this feature. And what direct connect is it provides a button that after you've done your first lens, like Brian described and you saw in the video, you can click on that and send information to the lab directly. So it's essentially being able to order the lens straight from the instrument. You minimize any sort of transcription errors by you having to take that information somewhere else. It all gets punched in directly. You just enter in, the patient's name. All that information would have already been there from the very beginning. So that'll all get put in there. All the lens parameters will be put in there as well. And then you can select, depending on different materials that you want, everything that you need to order this lens directly can get sent over to the labs. And they will also have access to the MSR file, which is the image that you see on the screen. So they can also help manipulate as well. So I think that's really helpful, because sometimes maybe we're not sure and we want the lab to see what we see. And so having that direct connect sends all this information to the lab directly with all the pertinent parameters that you need to design that lens, which is really nice.
Yeah, Heidi, I agree 100%. And you're absolutely right. It's literally as easy as clicking a button on the left-hand side. I think you mentioned, really, again, nothing gets lost in translation, over the phone. And I think that's a really important point for everyone to realize, that the labs do in fact see exactly what you see. It's not a PDF. It is the actual file that goes directly into their CAD CAM softwares. And then they can design the lenses, which again, really paves the way for those freeform designs in the future. So that's pretty amazing stuff.
Along those lines, I think one of the best features of ESP, one I really enjoy, is what I would term lab neutrality. And that is, Eaglet works with a variety, I believe over 18 labs, I'm sure even more than that now, with many designs within each lab. I'm sure the names on the screen now are familiar to many of us. I know that I use many of these different lenses for different applications. And just like to ask the panel, is there any one system or type of lens that you enjoy? Does something stand out here for any of you?
One thing that stands out, honestly, is how proud and appreciative that I am to all of these manufacturers for their contributions to improving their software. That's something that really wasn't the case even a couple of years ago. And so I would say that, all of these companies have come a very, very long way. And certainly is appreciated in our office. It's been a blast this last couple of months in particular, coming up to GSLS, where everybody's in a crunch to move things forward. And we've had a lot of fun using most of these designs, to be honest. There's some that are a little more commonly used than others, but I'll let somebody else take it over.
No, that's, I find that the labs love this for some of the reasons that Alex was saying. They see what you see, and they can really, really help us.
They do amazing things now. It's just incredible, the advancements in the software.
Absolutely.
And the thing is, the software's still developing. I know the guys are working on extra features, and we're talking a lot about sclerals here, but don't forget the sclera is important to soft, hybrid, and a cornea is important to GP. This is a topographer at the end of the day, and so we're getting data for any particular lens we want to fit. And I know AFIF is listening, would love the idea of fitting soft lenses accurately through proper height measurements and sag. So I think the whole process of more accurate fitting with ESP is going to get better and better and better.
Yeah, I agree. Those are great points. So we're running low on time. So I'd like to kind of wind this up here with a little Q&A, and I'd like to go around the panel. Brian, can you just briefly say, how do you feel like your specialty fitting has improved?
Specialty fitting has improved by accuracy, efficiency, speed, and better value. And that's better value for us as well. We've all said the same things pretty much, but in different ways and in different aspects of our ways to work. But specialty fitting is utterly crucial because they're a well-known bunch and they all know each other. Man, do they talk on social media amongst themselves. That works against us if we ever get things wrong, but boy, does it work for us, because most of our referrals are coming from some of the social media connections that people have. So to do an efficient, good value and quick, speedy, brilliant vision job is just paramount at the moment.
And Heidi, you're in a specialty clinic, a very specialized clinic. Tell me about fitting before ESP, the old school, and now with ESP. What differences have you found?
I think kind of just to reiterate what Brian said, it really has given more efficiency to the office. I work in a hospital setting and we're really heavily referral based. And so, a lot of times we get backlogged on scheduling patients. And I think for us, having an instrument like this, in terms of chair time, in terms of follow-up time, that's only allowing more patients to be seen on a sooner basis because we're not having to follow up as many times. The lenses are closer to the endpoint on the first or second lens. And that's really important, not just on the fitting aspect, but then we can see them back for follow-ups down the road. In terms of complications, there's probably going to be less because it's a more accurate fit. So it just really has been this trickle down effect, and it's all been really positive. Yeah.
We talked about more features to come, new labs, new programs, new programming. Sheila, I know you have an interest in orthokeratology. Can you share any information about how that applies maybe to the ESP?
There's definitely interest in it. And so probably over the next couple of months, we'll have a little bit more information. Currently, there's a beta test underway, and we're looking at utilizing the profilometry for OrthoK fits. We're about kind of halfway through getting data collected. And so it's definitely something that there's a lot of interest in globally to further use the instrument. So it's on the way. So beta testing for OrthoK, it's looking good so far. Tom, before I let you move on, I got another message just bringing, I think you already answered it in the panel, but did you want to just repeat for the entire audience regarding the use of Prepare Cane? I had another request on my cell phone asking
Oh.
if you could just repeat it, that it would benefit the whole group. Do we
Certainly.
all apply proparacaine or not, and fluorescein or not?
I know I do. We make sure the eye is lubricated, and we may even start them off with an artificial tear.
Mhm.
And then we do use proparacaine. And then we have several applications of fluorescein. We may start off with fluoresce, which is the liquid fluorescein and monoxynate, and then add a couple of strips of the fluorescein strips, the full glow or whatever. So yeah, you need a lot of fluorescein, but that comes with practice. And yeah, I think it's important. And for patient comfort, proparacaine, yes, definitely.
Tom, I didn't see the question. So is that about actually taking the scan in the first place?
Yes. Yes.
Yeah, okay. So if anybody wants to look on my social media, very open to everybody to have a look on BT Optom or the practice one. Then we did a video, myself and my colleague did a video, how we mix a little cocktail before every patient. And in the UK, I don't know if it happens in the US, but we get minims of fluorescein and proximeticaine we use. And so we kind of squirt them into a Petri dish and then suck back that. But we always add in a wetting agent. So we put in a high HA agent as well. So we've got a cocktail of fluorescein, anesthetic, and wetting agent, and it becomes a consistent mix. So the mix is always absolutely identical because you've got a measured amount of each one. So there's no kind of variation then on the thickness.
Yeah, that's a great video, and I'd recommend anybody to tune in. So Alex, we're gonna end with you. So wrap it up for us.
Well, yeah, again, I just have, can't have enough good things to say about the eye surface profiler. I just opened a private practice 3 months ago. We are in our infancy. And so the patient experience is even more important, maybe than, at any other time. Just it's so important to me that they have a very good experience. And we've done about 40 scleral patients since we've opened, and certainly the eye surface profiler has made that a whole lot easier and a whole lot better.
The future is so bright, we have to wear shades, right? That's great. Well, thank you all for attending today. Thank all the attendees who tuned in and listened to us. Thank you all to the panelists, and thank most of all to Arnie, Rayner, Tom Schoen, and Elena, and all the fine people at Eaglet Eye. And so it's been a pleasure, and look forward to seeing you in the future.
Wonderful. Thank you so much, Tom. And of course, all the other panelists, thank you for sharing your expertise, your experience, your wisdom. It's been really, really great. And thank you for all the people who came to listen to this Zoom. We'll keep coming with the questions to us. We have question forums on our website, and we've got all kinds of methods to keep you informed. There is scleralfitting.com, which has a lot of information about what lenses are connected right now. It also shows the different labs that we work with. They give the presentation of their lenses. So keep in touch with us, and we look forward to seeing you very soon. And a big word of thanks to all the panelists here, and thank you, and see you very soon.